What type of joint is a sternoclavicular joint? Saddle. What tethers the distal end of the clavicle, providing the primary support to the AC joint? Coracoclavicular, from the coracoid process going directly upwards on the trapezoid and condyloid part to where it's holding it down. You damage it and it does piano key signs. Which of the following muscles is primarily responsible for glenohumeral internal rotation? Subscap. So, supra, infra, teres are all classified as external rotators, which is a little funny because supraspinatus going directly over the top is at first 15 degrees of abduction. But eccentrically, as you internally rotate, it will slow you down. What bone articulates with the acromion process to make up the subacromial arch? Your clavicle does. What ligament finishes that off? What ligament finishes the roof over the glenoid? Coracoacromial. So it's that funky one that just goes from one landmark on the scapula to another. From the coracoid process, which is that, again, that little finger-like projection that sticks out from underneath, straight up and over to the acromion. What is the function of the subclavius? Clavicle depression. So again, this is the only muscle that's directly acting on the clavicle. Certainly that would impact the SC joint. Everything else from clavicle elevation or rotation is all created by us moving the humerus and pushing into the glenoid, which then creates motion from the distal upwards. Good with that? Good with that?
Yes.
Okay, just making sure.
Sorry.
It's all good. I do that frequently. How many degrees of abduction is possible by the shoulder complex? And when you say complex, you're meaning like the entire shoulder girdle.
180.
So 180. So if we talk about just the glenohumeral joint, we've got 120. Which ligament restricts superior translation of the proximal clavicle? This one was yours ago. So that costoclavicular ligament goes from the first rib up to the clavicle. So it's preventing it from elevating above. So as you elevate the clavicle in abduction, that costoclavicular, the costo is rib. What is the role of the infraspinatus muscle? That's external rotation. So what muscle abducts the humerus from past 15 degrees? What muscle abducts the humerus?
Supraspinatus does 0 to 15.
Supraspinatus is C, does abduction to 15 degrees. What takes over and finishes you off? Deltoids, thank you. You gotta talk louder. I'm old and deaf. All right, which of the following acts on the humerus to create motion of the glenohumeral joint? Solid in green. Teres major. What does serratus anterior do?
Protraction.
Well, I guess what group would you put A, B, and D in?
Scapular stabilizer.
Scapular stabilizers. So each one of those is attaching on either the spine or the ribs to then act on the scapula, whereas teres major originates on the scapula and ends on the humerus, right? Inserts on the humerus. So, protraction. Your shoulder punches, rotating that humerus, the scapula around into the front. Levator, it elevates it, shoulder shrug, and pec minor, what's it do? Where does it insert? What's that? Nope. So it's scapular stabilizer, not rotator cuff, right? So what's the insertion point? What's it attached to on the scapula? Yep. What is that? Coracoid process. Good job. Stop whispering. So coracoid process, yes. And so by doing that, because it's going ribs 3 through 5 up to coracoid, so it's pulling it forward. So it tips it forward. Okay. All right, so what are the six scapular stabilizers? So, let's work with groupings. Scapular stabilizers, what are they?
Trap.
Traps, levator scap,
Pec minor.
pec minor,
Rhomboids.
rhomboids,
Major.
major minor,
Serious anterior.
serratus anterior, 1, 2, 3, 4, 5, 6. Is that it? Yeah, good, so 6 in that group. Rotator cuff. How many muscles?
4.
4? What are they?
Super.
What's the acronym?
6.
SIDS, what are they?
Supraspinatus. Teres minor and subscap.
Cool. Glenohumeral movers. How many are there?
7.
7, what are they?
Deltoid.
Alright, so let's break this down just to help make sure we're getting all our pieces right. We'll go anterior,
This is head.
superior, posterior. There's going to be 3, 1, and 3. Okay? So, first of all, let's get the superior. What's the superior?
Deltoid.
Deltoids. And in large part, I want to do that because there's an anterior, a middle, and a posterior, and those are going to feed into those movements.
At the.
Alright, so what are my anteriors then? What's number 1? We can go pec major,
Biceps.
biceps brachii. Which head?
Both.
Good answer, both. What's the last one? Coracobrachialis. So focus on the fact that anterior muscles are going to do anterior things. Forward flexion, horizontal adduction. Anything in the front, these guys are assisting with in one way or another. So you're going to take deltoids, anterior delts, and add that into those motions as well. Deltoids, abduction. Posterior, 1, 2, and 3. What are they? Teres major. Lats.
Triceps.
Triceps, which head?
Short and
Long.
long.
There's 3 heads, medial, lateral, long. Long is the only one that crosses the joint. What's the origin of triceps long head? Done palpation on that? What's origin of biceps long?
Super glenoid.
Triceps long, infraglenoid tubercle. Biceps long, supraglenoid tubercle. Cool? All right. Shall we move on? Yay, more stuff. All right. Shoulder, shoulder, shoulder. Elbow, elbow. Elbow. We have, in large part, three main joints. 1, 2, and 3. Because we have 3 bones. 3 bones can articulate with each other in 3 different ways. So humeral ulnar, humeral radial, and radial ulnar. The main one we think of when we think about the movement of flexion extension, of the main actions at our elbow, is the humeral ulnar. Lock that in your head. The main joint we think of is that when we're thinking about the flexion and extension of the elbow, is the humeral ulnar articulation. That one. So, we got to pause for a second, make sure we're good with the landmarks, the articulation surfaces, and all the funky names that are going on in here, okay? So, humerus. We have a medial epicondyle, just like at the knee. We have a lateral epicondyle, just like at the knee. Good for that? Then we have lots of funky other colors. So my peach color that I just turned blue is called the trochlea. This is the articular surface of the humerus for the humeral ulnar joint. So when we think of flexion extension, this trochlea is the part that is articulating with the ulna. Next to that is a little guy called the capitulum. This is basically the rounded surface that the radial head just kind of pivots around when we go through flexion extension. So this capitulum is the humeral radial joint. So we'll do humeral radial first because it's pretty small and simple. We'll come back to the rest. But you can see that radial head, which is just kind of like a round disc, round surface. It just pivots over that capitulum as we go through that motion of flexion extension. You'll also notice there's a pretty significant bump right here called the radial tuberosity. Give me one guess. What inserts there? Anterior surface or posterior surface? Anterior. We're looking at the front. What's the biggest muscle you know of on the front of the elbow, front of the arm? Biceps. So deltoid has its own tuberosity, but when we're down at the elbow, so the biggest thing that comes in down here. So find it for a second. Take your hand, fist up. Go ahead and put it under the table like you're trying to lift it. Palpate your biceps and come down, and you'll be able to find that biceps tendon as it goes into that, into the radial tuberosity, into the radius. There's a test called the hook test. You basically get it to try to contract, take your finger, try to hook that tendon, and if it goes squish and you don't find it, then it's rupture. Pretty simple. All right. Ulna is all kinds of fun. So it's got quite a bit going on. If you take your hand and kind of form it in a C shape, that's kind of sort of what your ulna is like. Where the humerus, it's just the trochlea, just slides inside of that notch. So the major landmarks we then want to talk about are clearly where our fingers are bending in the back, which is called your olecranon. It's the point of your elbow. So that covers the back and really kind of protects the external surface of the joint. Sure enough, if we keep following it, you'll see how it actually looks like that olecranon is protruding into the humerus on full extension. So the back of the humerus actually has an olecranon fossa. So there's an indentation on the back, and you can feel it when you go and relax in full extension. You kind of feel into that groove a bit, but the olecranon is tucking into a gap, a space for it to go. So what's the limitation in full extension? What's limiting us going beyond that point? Which gets at the question of what is the end feel you would expect in a healthy, normal elbow?
Hard.
So we have three options, right? Soft, firm, and hard. Soft is muscle on muscle pushing, or soft tissue on soft tissue pushing each other, squishing into each other. Firm is typically a ligamentous limitation, to where the ligaments are taut enough that it's going to stop you from going farther, like a cable or a rope holding it. And hard is going to be because we have bone on bone. What do you expect here? Hard. Because we have the olecranon going into the olecranon fossa. We have bone going and tucking into bone. That's going to give us a limitation. Now, if we roll that back out, and again we go into the C shape, we have this little protrusion where your thumb would be. So that little protrusion right there. So it's called your coronoid. Probably the one time within the anatomy of the body that if you misspell it by a letter, you're getting a completely different landmark. Clarify in your mind coronoid from coracoid. Take the end, rotate it 90 degrees, and you've got coracoid. Don't let it confuse you. Coracoid's on the scapula, coronoid's on the elbow. The distal humerus has the coronoid fossa as well. So if I exit out of here, and where that dark blue is right there, is the coronoid fossa. So when I go into full flexion, there's a place for that little slot, that ulnar projection to kind of slot into. Now, going into full flexion, what do we expect as our end point? How do we expect that to feel? It's going to be soft because we've got biceps muscle kind of getting in the way. We've got forearm musculature getting in the way. So we have two pretty good muscle groups that are kind of bumping into each other. Now, in an unhealthy individual or somebody who's just exceptionally tiny, you can have a hard end feel to where that coronoid is bumping into the coronoid fossa, but it's got to go through that soft tissue. So if that soft tissue is small enough, emaciated enough, atrophied enough, then you can get a hard. But that's usually a pathological condition. It's not something you would normally expect to see. And there's your olecranon fossa. So, coronoid, coronoid fossa, olecranon, olecranon fossa, trochlea. What was the trochlea? What's the trochlea?
Articulation point of the femoral ulnar joint.
Right. Which bone is it on? Huh? Yes, on the humerus. Good. So trochlea is the articular surface of the humerus for that hinge elbow joint, for that humero-ulnar joint. So we also have the trochlear notch, which is really the inside of my little C shape, fit to hold on to the trochlea. So olecranon fossa, coronoid fossa, trochlear notch. Now, when we get an elbow dislocation, a lot of times it's when this ulna jumps posteriorly. In the process, if it's doing that, if you've got this humeral head sitting right here in that trochlear notch, and the ulna is jumping posterior, there's a good chance you're going to grab that coronoid and crack it. So posterior elbow dislocations, you have a higher risk of fracturing that coronoid process as it cleaves it off and that humerus jumps forward. So, full extension, 0 degrees of flexion, full flexion, 145-ish, depending upon the source you're looking at. So that's humeroradial that we did first. This one was humerulnar. What does that leave us? Radial ulnar. So let's pull radial ulnar back up. So what we have is a small little flat articular surface right there on the ulna. The radius just butts right up against it and rotates. What motion does that give us? Pronation, supination. So anatomical position is hands forward like this. And in large part because this feels more natural, somewhat, I think, to have your hands here rather than forward and exposed. But in this position, you're actually crossing the radius over the ulna, and so that muddies the water. So anatomical position is the two bones running perpendicular without crossing. So fully supinated. We get so pronation versus supination, about 70 degrees of pronation, about 85 degrees of supination. Yep. Yeah, sure. 70 degrees pronation, 85 degrees of 70 degrees pronation. Is that what you said? Yeah. Yeah. And 85 supination. All right, so let's chat about how to stabilize all this. Okay. First and foremost, you'll find we have a pretty significant joint capsule. Kind of sort of covers everything. Bless you. I'm going to jump the gun a little bit and just hide that whole thing out. So, on the medial side, what joint are we looking at? Which bones is that? Are those? Humerus and the... I got to vote for ulna. Ulna. Humero-ulnar joint medial side. This is going to be the ulnar collateral ligament, the UCL. What kind of force does it stabilize against? Valgus or varus? Got 2 votes for valgus. So, again, valgus kind of creates the L, the angulation that you get. Stabilize against a valgus force on the medial side, just like at the knee. Ulnar collateral ligament has 3 bands. There's an anterior, a posterior, and a transverse. Okay? The transverse is this guy right here. That's kind of going coronoid process back to the olecranon process. So it's really kind of like a rail that's on a freeway overpass. Kind of keeps the humeral head from shifting sideways and slipping out of that trochlear notch. So it's kind of like a guardrail. That's the term I was looking for. So that if it's running transverse, again, kind of like that coracoacromial ligament from one landmark on a bone to a different landmark on the same bone, it's just stabilizing some portion or the articular surfaces from slipping away from each other without actually connecting A to B.
So it keeps the radial head from slipping. Here, do that.
So trochlear notch, humeral head, and trochlear. Okay? So it's basically putting a cover here so that the trochlea can't slip out. Then we have anterior and posterior. Posterior is deep to a lot of muscle. We can't actually palpate it. Anterior, we tend to care about a bit more. It's the one we tend to mess up a lot when we're throwing a lot of baseball pitches. So these bands, you'll find that when you do upper eval, I see your arm, please. When I want to assess this ligament right in here for valgus stress, I want to do it both at full extension and put some pressure, as well as about 30 degrees of flexion, and then put some pressure. Because this is hitting more of my posterior, this is hitting more of my anterior banding. So it's going to be necessary to assess that UCL in different positions of flexion to help make sure that we're stressing the fibers along the entire way. A unique component. So the anterior band is palpable. So where you have, if you flex your forearm, you can kind of feel all of these flexor muscles bulge right here over the medial epicondyle. So that's your common flexor origin as you come up and in. So if you find that muscle, that grouping belly, and you slide up underneath it, you're getting into the anterior banding. Feels great, doesn't it? Just push on that spot really hard. Awesome. Okay, throw a baseball pitch. You wind up. You go into cocking, early phase, pre-cock, going into cocking. As you accelerate, you're leading with your elbow. So you're putting a lot of torque, valgus stress in that joint to open up that space. If you're throwing curveballs, then you're actually accentuating that as you're wrapping around instead of coming over the top. Great ways to tear up the anterior band of the UCL. Great ways to tear up the UCL in general. So the surgery that we use is called Tommy John surgery. So Tommy John was the first major league player that got this surgery. They took palmaris longus, so they took a tendon out of his left arm to then rebuild the UCL in his right. We now do this surgery for like 13 and 14-year-olds. Yeah, oops. So we're burning out elbows before they ever even make it to high school. That sounds not very smart. All right. So this is the medial stabilization. Kind of a dynamic joint series, as you can tell so far. We have 3 joints that are all kind of butting up against each other. Now, the knee, we had a medial, the MCL, we had a lateral, the LCL. Then we had our cruciates and other things. But we didn't have a lateral that was directly attached to the tibia. We have a lateral that went to the fibular head, right? The LCL drops down to the fibular head. Okay, well, in much the same way, if we go to the other side, we get the radial collateral ligament. So we have an ulnar collateral and a radial collateral, UCL and RCL. So, stabilizes against a varus force. Going back to our lovely conversation about kids and throwing. If we take that elbow, and they tend to limit how early kids can start throwing curveballs and stuff now, or try to, and pitch counts. But if I go and I have that valgus stress, not only is it opening up this side, but it's collapsing down this side. So the humeral ulnar is opening up, stretching out that UCL, but that radial ulnar, so the humeral radial on the other side, is collapsing in to where these articular surfaces here are then bumping into each other. So you can actually get OCDs, osteochondral defects, in and around the capitulum where the radial head is damaging and smacking into it. So an injury that younger kids tend to get when they're throwing, if you pull the kid out, let it heal and rest, it tends to do just fine. So it will resolve. But on that side, we have radial collateral ligament. Here. Now you'll notice in that its triangular shape that we have banding of it actually cut across and go onto the ulna. So it's actually a lateral stabilization of the humerus into the ulna. So this portion of the RCL, of the radial collateral ligament, is actually referred to as the lateral ulnar collateral ligament, the lateral UCL. So that means that the main joint that we have, this humeral ulnar that gives us this 0 to 145 hinge motion, flexion extension, is stabilized both medial and lateral. Medially by a very broad stretch of ligaments called the UCL with their 3 bands, but laterally there's also extensions of the radial collateral ligament into the ulna, which gives us the lateral ulnar collateral ligament. A reason that, again, we tend to want to name things and be able to articulate about anatomical features, especially when we have a high likelihood of injury to them. So I've seen it once with a hyperextension, more frequently you see it with a previous history of dislocations, but if you disrupt this lateral ulnar collateral ligament, then you have rotary instability. So what does that mean? That means that if you've dislocated your elbow, and it's been put back in, and you've gotten strength and rehab, but this isn't resolved, that if you pronate and extend, so that force of pronation with extension creates a rotary instability to where it shifts and it's unstable. So every time you walk up to push a door open, your elbow is going to pop and shift. We call it the chair test or the sit test, where you're here, you have someone put their hands on a table, again, pronation with extension, and you have them try to push themselves up, it'll shift and that arm will give out if that ligament is unstable. So, piece to know. So there's 3 ligaments, UCL, RCL. Behind the RCL, or the posterior fibers, or the lateral ulnar collateral, the LUCL. And that leaves this band right here, which wraps around the radial head. So it's called the annular ligament, A-N-N-U-L-A-R. Where have you heard that term before? Annular. Annulus. Why? Annulus fibrosis, which is part of what? What was the annulus fibrosis? In the spine. What did it do in the spine? You know, come on. So is it disc or is it vertebra? Annulus fibrosis is the the outside of the jelly donut. So the discs, the outside rings, annulus means ring, outside rings of the discs are fibers that interlock. I mean, they're alternating fibers that go opposite directions. And then we tuck inside the nucleus pulposus. So those rings are resisting rotation. Those rings are assisting us in allowing to have rotation, but it resists it at the same time. But annulus, annular ligament, annulus fibrosus, annually cyclical, rings. Got it? So it's basically just grabbing that radial head, and you can feel this. So if you palpate, again, find that biceps tendon into its insertion. And you can kind of feel in the back, off your olecranon, there's a little bit of a secondary bump on the lateral side. So if you go a little bit lateral off of biceps, and then you twist, pronation, supination, you can feel more under your fingers than your thumb, but you can feel the radial head just pivot under your arm, under your fingers. The other way to do it is to extend, and you can grab that common extensor origin, which is all that muscle mass right in there. Get underneath it, get lateral, posterolateral to it, and then you'll find that radial bone, find that radial head. And then you can twist again, and you'll feel the radius kind of spin under your fingers. Good? 4 ligaments, nice and easy. Guys ever heard of nursemaid's elbow? Not so much. So you can take a kid and either get mad at the kid and take the arm and yank it, like, come on, hurry up, let's go, let's go, let's go. And you're yanking the kid, you're like, ah, ah, ah. Or you take a kid who is standing between mom and dad and they put their arms out like this because they want to get swung. So if we have a traction force, you can actually take the radial head and slip it out of the annular ligament. And then CPS gets involved because it looks like child abuse. The resolution to that is not too actually difficult. If you get them into flexion and do some pronation extension, supination, excuse me, it'll actually slip it right back in. They're still going to be very sore. You should have an orthopedic checkup on it. But the ER will call CPS on you. Now, if it is because you're yanking the kid, you should probably calm down a little bit. Simmer down now. All right. Cool. So let's talk elbow flexion extension real fast. Things that we need to know. Which one do you want first? Flexion or extension? Do some muscles. Flexion. Cool. 3 of them. Biceps brachii. So biceps brachii comes together, inserts into the radial tuberosity. You'll see this kind of faint shadowing right here. There's actually fibers coming off of the biceps that go out into the fascia. So it's not just grabbing and flexing via the radial tuberosity attachment, but it's actually going out into the fascia to hit all of that soft tissue and pull it all up at once. So it's geared very much to help create that flexion. Long head and short head we talked about. Short head originates where? Biceps brachii, radial tuberosity insertion, short head, coracoid process. Long head, where is its origin? Supraglenoid tubercle, above the glenoid tubercle. You absolutely have to hold on to that because when you start talking about slap lesions, it becomes very important. So that's number 1. Testing that. If you're going to look at its specific positioning, if you are in supination, this is the position that you will test for biceps brachii. Here. If we rotate 90 degrees into neutral on pronation supination. This is my favorite muscle. So, take your hand and tuck it up underneath your table like you're trying to flex it. So neutral between supination and pronation. And lift up. And you'll get a muscle to pop right on the top. This is brachioradialis. So it's originating, you can feel, on the distal shaft of the humerus. And it goes down to the distal radius. So it extends most of your forearm. Easiest way to work this out is 12-ounce curls. Grab your favorite can of Coke, and you're going to get a good lift. Now, if that's too heavy, you could always downgrade it 8 ounces of wine. And if you really need to do some remediation work, you can do 1-ounce shots. Now, if you're really hardcore, you can step up to 40s. But just be mindful, that means like 40 ounces of water. Shots of water. Coffee, whatever. Espresso, there we go. Shots of espresso. Better? Better. Good to go. All right, so brachioradialis, you're going to manual muscle test that right in here, in neutral. Now, if you roll it one more time and go full pronation, there's a muscle called brachialis hiding underneath. So there's brachioradialis, and sitting underneath biceps brachii from about the mid shaft, about a third of the way down off of the superior end, is brachialis. Sits underneath the biceps brachii, and you can muscle test it in full pronation a little easier. Now, there's a reason that we can help. There's one more action that the biceps brachii has that helps this position isolate brachialis. So biceps brachii, with its insertion, actually as you do curls, you can still do supination. So biceps brachii actually assists with supination. So if I go into full pronation, then I shorten it. Is that right? Fully shorten. I take out some of its leverage. Doesn't necessarily shorten it. But it helps isolate brachialis from biceps brachii. Anyways, biceps brachii, brachialis, biceps brachii, brachioradialis, brachialis. That's my 3 flexors for the elbow. Cool? Biceps brachii, short and long head, brachioradialis in neutral, and then fully pronated is brachialis. Now elbow extension. We have triceps brachii. 3 heads, medial, lateral, medial, oops, long, lateral, medial's underneath. There it is. Medial, lateral, and then long. All 3 work together to extend the elbow. The trick, though, anybody ever spend some significant amount of time in the gym, like for upper body work? You can hit a plateau very quickly with triceps. And the reason for that, if you're doing just the same exercise all the time, is because each one of those is a little more mechanically adventitious based upon the amount of rotation that's in the joint, in the arm. So if I'm always doing my triceps in the same way, I'm really working 1, maybe 2, I'll work all 3 heads, but 1 or 2 of them is going to be selected based upon the leverage it has to make that pull. So you need to do tricep exercises in multiple ranges of motion. Overhead, dips, pull downs, because that way you're doing different degrees of rotation with the humerus, which helps make sure that you're working the triceps in all of its range of motion. Now, there's a cool little muscle right here called your anconeus. Now, this says the action is that it extends the forearm at the elbow. Don't believe that for a minute. It assists with the motion of flexion extension by stabilizing the ulna as you go into extension. So as you come out, it's firing to help hold the ulna in rotation in a specific position so the triceps can do their job. So the anconeus is an assisting muscle that it's not creating elbow extension, but it's stabilizing that ulna into the humerus, kind of pulling it in place to hold it there. If you go back, we had the popliteus, which created some rotation to allow us to unlock that screw-home mechanism, right? So it's an assist muscle, kind of like that, to where it's just holding that ulnar, the olecranon, holding the ulna in a particular rotation point to keep everything stable and secure.
So it's not part of the extension.
You're going to keep it, because it's assisting with elbow extension, you want to put it in that conversation. But if I ask if it's specifically extending the elbow, that's not its principal role. Certainly with that kind of position, it doesn't have leverage to do so.
So it's an assisting muscle.
Yeah, and it stabilizes the bones so that throughout that range of motion that things are held together. All right. Time for a whirlwind. We're going to start with flexors of the forearm. Okay? We'll learn these first, then we'll go back in and add the extensors. But we'll use the trick we do on the forearm to learn the extensors. Bless you. Ready? Take your hand. This is wrist finger flexors. Okay? So everything that is pulling forward. Now, if I ask you which side that's on, you can find it pretty quick, because if you go into flexion, you can feel which side is tightening up. So this is medial. And as the more you flex, you can just feel that whole mass lock up and attach, like lock up and contract. Okay, so take your left hand. I want to put the heel of your hand in the crook of your elbow to where ring finger is on the ulna, index finger is on the radius, middle finger, that one right there, is going up the middle, and your thumb is shooting off diagonal. Now, like drinking tea with English folk, let your pinky hang off the side. We're not going to care about him so much. So just ignore that the pinky's there. See, it's gone. It's a magic trick. Okay. Each one of these is going to represent a layer of muscle, or a position of a muscle. We'll start with your thumb. The diagonal orientation, this is your Pronator Teres. So again, it's going, like we've done with other muscles, recognize the origin, see the direction that it goes to the insertion, and if I pulled, I'm pulling it diagonally over, so I'm creating pronation. Pronator Teres. Then we're going to focus on your ring finger here and your index finger as they sit over the top. Flexor, carpi, radialis is your index. Flexor, carpi, ulnaris is your ring finger. Carpi is referencing the fact they're inserting on the carpal bones, the 8 small bones in the base of the hand. Flexor carpi radialis, flexor carpi ulnaris, grabbing the carpals, and they're flexing the hand. What joint are they acting at? What joint are they acting on? What are they flexing? Your wrist. So they're coming here over the carpal bones, which are the two layers of bones that are right at the base of the hand, pulling in so it's flexing your wrist. So if you were to see a picture that's highlighted, it has a muscle highlighted, and you see that the tendon is inserting into the thumb side carpal bones, you're going to know, based upon that tendon's insertion, it's flexor carpi ulnaris, radialis, under the thumb, radialis. Let's go on pinky side, flexor carpi ulnaris. So the origin is going to look the same, but by following it out and seeing where it goes, you can figure out what it's going to do. Got it? Now the middle finger, over the top. We're going to have three muscles that are layered. The first one is palmaris longus. Palmaris longus actually inserts into the fascia of the palm of your hand. So it's a weak wrist flexor because it's grabbing the fascia, the soft tissue, and helping it pull forward. Weak enough that we can pull it out and go do some Tommy John surgery, and you're really not going to notice that we took a whole muscle out of your left arm. Doesn't do a whole lot. Isn't that big. A layer beneath that, flexor digitorum superficialis. Superficialis means that it's superficial. It's closer to the surface. Flexor flexes digitorum, the digits, superficialis. It's more superficial than the other flexor. FDS. We will frequently refer to this one as FDS. The action of this is to flex. It will assist with wrist flexion. It will assist with metacarpal phalangeal flexion. And then it's going to end on the middle phalanx. So it's going to give us strength in our grip. This muscle is geared for strength and grip. It's going to grab here on the middle, not the distal phalanx. Last muscle, then I'll leave you alone for today. Maybe. I might be lying. Deep to that is FDP, flexor digitorum profundus. Flexor digitorum profundus. So FDP goes to the tips of your fingers. It goes to your distal digits, to the distal phalanx. Crosses the distal interphalangeal joints. This is fine motor skill. So strength comes from FDS. Fine motor skills coming from FDP. All right, two muscles that are left. I lied. Flexor pollicis longus. That's exactly what it says. It flexes the pollex. Your thumb, flexor pollicis longus, flexes your thumb. And the last cool muscle we have, Pronator Quadratus. So this is your wristwatch muscle. So right where your watch would fall on your wrist forearm, underneath that is Pronator Quadratus, which assists with pronation, assists with the Pronator Teres in pulling it forward across. I strongly encourage you to work on getting the muscles of the forearm on the flexor side anchored in your memory today. When we come back on Thursday, we're going to work on the extensors, but we will use this trick to help explain the ones on the back as well. So we'll make it so much easier if that part is already embedded in your head. Cool? All right.